Real.
A very good evening, everyone. Welcome to iFocus Online, Lecture 212, Retina Lecture 64. It is a special lecture by Professor BNR Subudhi on challenges and opportunities in diabetic retinopathy screening. I request Dr. Ritesh Narula, sir, to please welcome and introduce our lecture today.
Thank you, Shefali. First of all, I would like to thank Dr. Subudhi for coming here and being a part of iFocus. Hats off to Dr. Santosh Anawar for this particular topic in particular. This is such an interesting topic, something which we don't discuss that very often. Where tele-ophthalmology and diabetic retinopathy screening, which is now the future of diabetic retinopathy for a country like India, and who better than Dr. Subudhi here with us to talk about it. Welcome, Dr. Subudhi. To introduce him, sir is a graduate, postgraduate from Berhampur University. Subsequently, he is currently the chairman of Ruby Eye Hospital, Berhampur. Today, for this particular talk, his major credentials that are there are his work in community ophthalmology that he is doing, and the pioneering work that he is doing in tele-ophthalmology, especially with regards diabetic retinopathy screening. And really looking forward to listen to you, sir. Over to you.
Let me share this. So, thank you, Mr. Ritesh, Dr. Shefali, for introducing me. And I'm happy that as Ritesh told me that he will be introducing very briefly and highlighting my community work. Really, thank you, Dr. Ritesh, for introducing me into this August audience. So, before I start my lecture, I must thank Dr. Santosh Anawar, a great academician of our country, and his iFocus online and of course CFS, giving this opportunity to speak in front of an august audience of postgraduate students, fellows, consultants. A very interesting topic, as Dr. Ritesh told already, a very burning topic, diabetic retinopathy. And our country now needs a lot of work to be done for the both awareness, screening, and also the management of diabetic retinopathy. Some of the lectures already been completed about the etiopathogenesis, management. Also, half of the this screening has been covered by my extreme friend, Dr. Rajiv Raman from Shankar Netralaya. However, I would like to highlight certain points. I don't have any financial interest in this presentation. Before I start my topic, I would like to describe at least 3 cases. There are hundreds of cases we come across, and very peculiar cases, you can say. The number 1 case is T1. It's a male 37-year-old man, occupation by lift operator, works heavy physical work is normal with him, and reported to us with a decreased vision for last 15 days. He was found to be diabetic only 6 months back. Now diabetes well controlled and under treatment by a diabetologist. But you can see, if you see his fundus, both fundus, they are having advanced PDR. Case history 2. A 58-year-old patient from Bhubaneswar, our state capital. I am working at Berhampur, about 150 kilometers south to Bhubaneswar, as a city. And this person came from Bhubaneswar, our state capital, to us with a sudden loss of vision left eye 15 days back. And he was diabetes his last 12 years under regular treatment. An examination of left eye showed vitreous hemorrhage, right eye PDR. And he is always under regular treatment with the diabetologist, but he has not checked his eyes last 4 years and never advised by the diabetologist. And third case history is that a 75-year-old man came with a mature cataract both eyes for surgery. And routinely we checked up his blood sugar showed 327 milligram. You know, this patient also is not aware of his blood sugar. So what are these issues? Case number 1, 37-year-old man, a physical worker, never knew that he has got diabetes and is almost asymptomatic. routinely found out to be diabetic and has advanced diabetic retinopathy. Second case, no doubt he is already in an urban area, is under proper treatment, regular treatment. However, he has not been advised to do the eye checkup in the last 4 years. And third case, the person reached up to the age of 75 years, but he has never been detected to be having a blood sugar, diabetes in the past year. So what I mean to say, all diabetics, all normal people should check their blood sugar after the age of 40 years, routine checkup. So it's very sad that proper counseling by GPs and physicians is lacking in our country, and also routine screening for diabetes and DR is not done. So awareness and screening are the two key factors in the prevention of diabetic blindness. As you know, diabetes is a major public health problem in India, and diabetic retinopathy is a very important cause of avoidable blindness. Up to 98% of diabetic retinopathy-related visual impairment can be avoided, can be prevented by early screening and prompt management at time. The prevalence of diabetic retinopathy is increasing at an alarming rate. There are about 77 million diabetes in our country, and more than that, I would say the number is growing rapidly, more so during COVID and post-COVID times. The increase in diabetic and diabetic complications in the post-COVID area, post-COVID period, mostly due to steroid overuse or misuse during the diabetic patients, during the COVID patients, and also direct damage to the beta cells by the coronavirus, direct damage. So there's already studies then. Gitika Sachdev has already said in a journal that the coronavirus directly attacks the beta cells of the pancreas, giving rise to diabetes. So, diabetic retinopathy screening, alongside with the prompt management for those who need it, as an effective intervention for all people with diabetes to prevent vision loss due to diabetic retinopathy. So, what are the aims and objectives of the screening program? What we suggest? So, aims of the screening program is early detection of diabetic retinopathy changes and early referral for treatment to prevent blindness. These are the two important factors. And as you know, everybody knows, all diabetics to get annual retina screening for the life, and type 1 diabetes should have retina checkup after 5 years of diagnosis, whereas the type 2 diabetics at the time of diagnosis and yearly thereafter, routinely blood sugar should be checked and retina should be checked. So this diabetic retinopathy poses a lot of challenges to us, mostly the community ophthalmologists. We do a lot of work in the community and we find a lot of challenges. India is a vast country with diverse cultural heritage, and it is such a geographically located that a lot of remote areas, lot of hilly areas, lot of tribal areas where a person cannot reach. And these, they play a major role, a critical role in delaying the diagnosis of many eye diseases like diabetic retinopathy, glaucoma, and ARMD, so and so. So all the diseases could have been detected if these people were staying in the proper, urban areas or whereas reachable areas. If you see the statistics, number of diabetics among the poor is increasing. Diabetes is more common now, low socioeconomic status group, and awareness is the casualty. You see, this 80% of people, they remain with the uncontrolled blood sugar levels. This is a very most important finding you can see. And if you see these statistics here, HbA1c is more than 8%, almost all the cities of our country. That shows that how well controlled our diabetes, irrespective of our the advanced technology, advanced science, advanced treatment also. If you reduce HbA1c by 1%, there will be reduction of eye complications by 31%. So every time we must do HbA1c estimation, and we must reduce or bring our blood sugar back less than 7. So what are the key issues for this DR screening? There are community issues, there are doctors issues, patients issues, and infrastructure issues. So what are the community issues? 80% of people live in the rural areas in our country. and illiteracy and low awareness is the most common among these people. Of course, low economy is another factor, because majority of the people, they live on 2 meals per day and mostly containing rice. Particularly South Indian people is mostly rice eaters. And as the COVID and post-COVID, as the treatment has increased, I mean, the cost of the treatment has increased, and there's expensive treatment, and even in spite of the government's help, still then the treatment is not possible by a common man to get for the diabetic retinopathy. Another most important is the poor referral. Who do not, our colleagues, our friends, physicians, they do not refer the patient to the proper place. And the patient also doesn't know where to go, where to show, to whom they should show. So awareness and counseling by the physicians is very poor. Doctors' issues. In our country, anybody can practice diabetes. If a MBBS doctor, after the 2 months certification course, can practice diabetes and is a popular diabetologist. A lot of lab technicians who do regular blood sugar with a lot of experience, they also treat the diabetes patients. Physicians, mostly Ayush doctors, they are also they treat the diabetes patients. So, these people, they have least knowledge about the modern classification, modern stage of diabetic retinopathy. And they do not know when to send the patient, when to check the eyes, when to check the other complications of the diabetes. Poor awareness counseling by the physicians, and of course, poor referral to the ophthalmologist. They do not know when to send the patient to the ophthalmologist for eye checkup. So these are the major issues by the doctors in our country, particularly those who are treating diabetes. But the patient's issues, uncontrolled diabetes, even in spite of getting the drugs properly, even in pre-treatment, pre-drugs by state government counters, but still uncontrolled diabetes is very common in rural areas, particularly because of lack of education. And they are not also ever the diabetic complications, the heart complication, kidney complication, they do not know. Many times when you ask them, why didn't you show your eyes quite before? So we are not aware. Nobody has told us that the diabetes can lead to all these complications. And of course, poor infrastructure, rural community, hardly you can get a hospital, hardly you can get a primary health center. Patient has to walk kilometers together, maybe 2 kilometers, 3 kilometers to reach a hospital. And they are mostly treated by the quacks. And health workers, even they are there in the rural areas, but they do not counsel the patients, particularly diabetic patients, properly. Infrastructure issues, as already I told you that majority of part of India in the rural areas, unreached areas, even there are hospitals, but there are no doctors. Even sometimes a small hospital is maintained by a pharmacist or even other lab tech people. Eye care hospitals still further, there are very few. Hardly you can get a district where you get a eye care hospital. Financial constraints for the low socioeconomic group is still more important. And another important factor is the accessing diabetic care is also very difficult, because they have to walk quite a long time. And most of the people are elderly people, they cannot walk, they need assistance. Another, if an assistant has to go with their parents or the relatives, he has to lose his daily wage. So these are the various issues in the infrastructure issues. So there are a lot of challenges for the DR management, as you know, because there are diagnosis, investigation, management, particularly in the rural areas, very poor. So people, they do not get the proper management, timely treatment. And moreover, the diabetes, even diabetic retinopathy, they are asymptomatic in the initial stages until the complications arise. They do not bother to show to the doctor. Late presentation to the ophthalmologist. Moreover, retina specialists are very few in our country. Most of the people after MBBS, after post-graduation, they prefer fellowship in cataract and cornea, to a certain extent glaucoma. But then people, they do not come for the retina practice, because in our country, retina practice is very poor and lack of good referral system. However, there are a lot of opportunities for us to do a proper and a correct diabetic retinopathy screening, a timely screening can help the patients and prevent the major complications. So some of the measures we have to take: massive awareness, display of banners, public meetings, distribution of leaflets, media, television, through whatever media you get, whatever medium you get, you have to create awareness in the people, particularly in the rural areas, and of course screening. In this category, now the role of tele-ophthalmology with AI plays a major role. I will be discussing later. And of course, last but not the least is the National Digital Diabetes Registry. I will let you know. So awareness is very important. Wherever possible, whether the laboratory, where the pathology laboratories, where the blood sugar is tested, clinics, any clinic, whether the Ayush clinic, a primary health center, secondary care center, a gynecologist chamber, wherever possible, we have to put these banners. We have to instill the ideas that the diabetes can lead to blindness. All these banners we have prepared in the past for the IMA PDB program, and even at the top city places, where the public places where the people frequently visit, parks, stations, bus stands. So these banners should be posted. Media plays a major role. If we can induct sign actors like Amitabh Bachchan, Karishma Kapoor, and last our Mr. Siddhant Mahapatra, sign actor of Odisha. So these are the celebrities. They can give a good message to the people in a better way. If you can have a small video. So if a common man speaks this, probably we cannot accept it. But Mr. Amitabh Bachchan says, then probably we can accept it better. So these are the celebrities have a following, and we can, through them, at least we can create awareness in society. After awareness, screening is very important. So all diabetics in the country, about 77 million diabetics, more than that, they should be screened. Who can screen? Anybody. A ophthalmologist, physician. A physician can keep a small ophthalmoscope in his chamber, even also non-magnetic cameras he can keep, or some mobile cameras he can keep in his chamber. He can do the screening. Optometrists, ophthalmic assistants, who have the skill of screening of DR, and of course any trained field level worker. We will discuss later in the tele-ophthalmology. How to screen? Any instrument which can show the fundus, not only indirect ophthalmoscope, slit lamp biomicroscope, but modern day, your smartphone fundus can be examined with the smartphone. So these are the cheap and easily carried, and also it is economic. So these are the instruments one can use to screen. Whom to screen? People with known disease, known diabetics, all must be screened. As I told, annual screening is a must for all diabetics. Opportunity screening. In whichever clinic the patient visits, whether it's a gynecologist clinic, whether it's endo clinic, surgery clinic, wherever it is possible, one has to do a screening. So massive screening is very important. And of course, mass screening in the camps. We must hold camps periodically in different parts of the country, mostly rural areas. So all busy ophthalmologists of our country should find out some time, maybe 2 to 3 hours every weekend, go to a rural area, do a screening. In that way, we can detect many diabetics and prevent the blindness. So these are the various cameras available in the country presently. So one can use The cheaper cameras are available, and these are the various cameras. So new developments in the screening, one is the tele-ophthalmology and artificial intelligence. Tele-ophthalmology is a branch of telehealth, has evolved into an integral clinical tool in the Indian healthcare system, more so during the COVID times. It's an effective model for improving the eye care delivery system in the rural and underserved areas of the country. Wherever a doctor cannot reach, but a teleophthalmology equipment can reach to these areas. It allowed clinicians to provide quality health care outside the clinics, taking the technology to the rural areas for the screening and management. It has the potential to improve ophthalmic care and diagnose many eye diseases in the early stages like diabetic retinopathy, glaucoma, ARMD, even refractive errors also can be detected by this process. It will provide high quality, cost-effective community eye care at the doorsteps of the community. And we have utilized the tele-ophthalmology for the DR screening, and is one of the most recent developments. So remote interpretation of the images, fundus images taken by a trained non-physician graders, some +2 students or health workers, they can be trained how to take the photographs. So they can take the photographs, and somebody sitting in the central place, they can grade these images by which you can know that whether the patient is diabetic retinopathy or patient is no diabetic retinopathy. And once you see that the findings are detected, they must be communicated properly to the patient, who can be counseled properly about the management. Then only our screening will be successful. Of course, nowadays, the artificial intelligence is knocking at the door of us, all the healthcare profession, and probably we are the benefited most by this AI. AI, which could be used to detect about diabetic retinopathy from images captured from any imaging device. It can be incorporated. That will detect whether the patient is DR or patient no DR. Automated image analysis is very accurate of the research. It goes, the research is continuing. Let us listen to this video by none other than Mr. Sundar Pichai.
Sir, your audio is not audible, sir. The video is on.
Oh, I'm sorry.
Can you help, please?
I don't think so. Now I can. Okay, leave it. No audio, or just like the audio is there?
So only the video can be seen. Audio is not heard, sir.
Oh, good. Okay. Anyhow, it's all right.
So on the screenshot tab, there is a 3 dots which says share computer sound, share or computer audio.
Here?
Just click on that.
Share sound.
If you can play now, you'll be able to hear those.
Treatments are effective. If detected late, it causes irreversible blindness. And it's very, very difficult to have highly trained doctors available in many parts of the world. So we set out to work with a small team of engineers and doctors, and again used deep learning and started training on eye scans. And over time, our computer vision systems have gotten really good at detecting diabetic retinopathy early. This is still early, and there's a long road ahead, and we'll work with the medical community to get it in the hands of as many people as possible. But you can see the promise again of using machine learning. When I hear about advancements like these, I'm reminded that we live in an extraordinary period for computing. Whether climate change, healthcare, or education, the most important struggles already have thousands of brilliant and dedicated people working to make progress on issues that affect everyone. Now consider what the best climate change researchers, doctors, or educators can do with the power of machine learning assisting them. As you have seen today, I'm incredibly excited about the progress that we are making with machine learning and AI. We believe that the real test is whether humans can achieve a lot more with the support of AI assisting them. Things previously thought to be impossible may in fact be possible. We look forward to building this future together with all of you. Thank you for joining us.
I'm sorry, it is not audible properly.
Was audible,
So this,
not a problem. It was quite audible.
Achha, okay, thank you so much. So this camera recently launched by one of the company, Remedio company. I don't have any financial interest for this machine, but it has everything. It's a non-mediatic imaging machine, auto capture, no specialist needed, no human grading, automatic grading is there, no even offline also it can be record, take the photographs, instant diabetic retinopathy results. So this has got a 93% sensitivity and 92.5 specificity. So these are the cameras we can give to the mostly say is a +2 students or health workers. Just give the training how to handle the camera. They can go to the periphery, the rural areas, and they do the door-to-door survey and take the photographs. They have to take the only photographs properly. That's nothing they have to do. And automatically these are transferred to the nearby hospital where it can be graded. So you know how the AI now slowly entering into the further screening of diabetic retinopathy. Coming years, maybe few years ahead, so tele-ophthalmology will be one of the finest mode or source for the prevention of many eye diseases like diabetic retinopathy. So telemedicine diabetic retinopathy screening programs will have a significant impact on the vision complications and healthcare burden from the growing diabetes epidemic. So if eye care at the government setup, it has to be geared up. So if you see this pyramid, everybody knows this pyramid, how it works. Now, vision guardians, who are there? These are the health workers in the rural areas. They can take the photographs with their camera. Then they transfer the camera to the vision centers. Vision center, as you know, every 50,000 population, there should be a optometrist or ophthalmic assistant. He handles these vision centers, where all these images are transferred to this place. And he, with a little bit training, he grades the images. And once the images are graded, whether the patient needs any treatment or patient doesn't need any treatment, whether referable or non-referable. If non-referable, the patient goes back to again vision guardian for the counseling. For that again repeat checkup maybe after 6 months to 1 year. And if it's referable, then you go to the secondary care center where the facilities for lasers and intraocular injections are available. And the ophthalmologists are available at these secondary care centers. And any patient needs more higher treatment, it goes to tertiary care centers, mostly established the state capitals. And of course, a center of excellence can be set up either in the center, New Delhi, or in the various zones, so that at least this center gives advanced surgical techniques and also the research and training also. So this pyramid has to be activated. It is there, but not activated till date. So whatever I told, the vision centers, they should be well equipped with the non-mediative fundus camera and trained optometrists may be present. Secondary care centers, yes, more secondary care centers should be placed district places. So where all these facilities, a simple laser machine should be available, nothing more than that. And of course, tertiary care centers in the state capitals and the cities. So they should also give a long-term training ophthalmologist in retina, like in our country, most of the hospitals in the rural, southern part, they give this long-term training of retina for about 2 years. So providing advanced VR surgeries and of course advanced tele-ophthalmology setup. So this is the last part. I am very much concerned about this. So advanced tele-ophthalmology setup should be established as tertiary care centers, and we should develop a tele-ophthalmology network all throughout the country, where the ophthalmologists and the optometrists and the patients will be connected. And of course, Apex Center for the Center for Excellence and for Advanced Treatment and Research. So coming back, the most important, message for this webinar. The awareness and screening are the two keywords. Various committees have been constituted to create awareness and screening. One of such committees is the AIOS DR Task Force Committee. If our president, Dr. Lalit Agarwal is looking into this, listening to us, so he can tell us, or he was a part of this program few years back. Now this program is somehow in the back foot, and I think I request to Dr. Lalit to look into this and revive this AIOS DR task force. We have done a lot of work on this in this committee, and we have also submitted our reports. I request our president to look into this matter again, revive this committee. And of course, another committee is there. Regularly, we are doing. I am the part of this committee. I am a standing committee for the PDB, Prevention of Diabetes Blindness, has been working to create awareness in the society, also screen all diabetes in the country. ACOIN, a community ophthalmic society working in the rural areas, and we also a part of, do a door-to-door survey of the people for particularly blinding diseases, diabetic retinopathy, glaucoma, ARMD, refractive errors, and some congenital disorders also. So Tele-ophthalmology Society was recently established, just 1 year old. Our aim is to create awareness in the society and to reach the community for screening of all diabetics, with our Professor Natarajan as the Chief President of the society, and Dr. Kim, and another gentleman from Arvind is our President-elect. Dr. Rajiv Raman is the Vice President, myself is the Honorary Secretary for the society, and all these people are members from different parts of the country. So our dream is to, eye care should reach every village in India to eliminate preventive blindness, to eliminate diabetes-related blindness from India by 2025, making India diabetes blindness free. And our aim is to do a door-to-door survey for prevention of diabetes blindness, and also strengthen the referral pattern. It's very important because the referral is lacking in our country. Doctors, they do not refer the patients to another doctor. So this is the methodology we have adopted, and we will be working in the future to, particularly in the prevention of diabetes blindness. So by another 5 years, we can make India free of burden of diabetes blindness, and tele-ophthalmology can show us the path. GPs, primary care physicians, and other caregivers can easily diagnose referable diabetic retinopathy by using these simple techniques and simple machines. The potential to make a huge impact both on the disease's social and economic dimensions. This is another model, Singapore model. This has been launched in 2010 in their country, and they're doing wonderful. So they have utilized artificial intelligence. It is a model. If we can follow, probably we can also achieve the diabetic blindness-free country in coming years. This is the model, SIDRP. But whatever we do, we need more working hands. We have to coordinate with the physicians. We have to coordinate with the optometrists. We have to work together. And also we have to give training to some unskilled workers. Just a short-term training, maybe 2 weeks, 4 weeks. In tele-ophthalmology, doing short-term training. Recently, we have the training on the diabetic retinopathy, grading, staging, and now we are going for the grading. We select some optometrists and we teach them how to grade the images so that they will be helpful to us in our pursuit for the prevention of diabetic blindness. And we have also devised a Odisha model. Shortly, we will be starting this Odisha model in our state, and later we will make a replica of this model in almost all other states of our country. This is the CAM setup from the patient registration to treatment. So all this will be done in a CAM setup. Last but not the least, make a national diabetic registry. There are about more than 77 million diabetics in our country. But do you have a register? Do you have a knowledge where they are, how they are treated, whether they are taking the treatment properly? So this can be done by a national diabetes registry, particularly digital register. Now the government of India is giving much importance to digital health. Probably we can work together. We can push our government to create a diabetes register, a digital diabetes register, where all diabetes will be registered with a pre-registration, and this registration will have all the record, what the treatment patient is taking, whom he is showing, whether he has been properly followed, whether he has been properly treated. So this will be our achievement if we can do in the next 5 years. So simply I can say that ABCD, this is our Dr. Natarajan's message. Anybody can screen diabetic retinopathy, provided a little bit training is necessary. And of course, this is our AIO's initiative in the past 4 years, screening through tele-ophthalmology for prevention of diabetic blindness, stop blindness, Jot se Jot Jalao. This is our slogan in the last 4 years by the AIO's DR task force. Let us join together and prevent diabetic blindness. AIO's DR committee, Tele-Ophthalmology Society of India, I am a PDB committee, ECOIN, NGOs, Rotary Lines, and government. If all join together, probably you can achieve the diabetic free India. And our slogan should be a national slogan: beat diabetic blindness by screening all diabetics. So let us make an effort in our country to make diabetic blindness free by a certain target period, so that at least we can achieve the success. So thank you very much for patient listening. I think I have given a very broad outlook of what Tele-Ophthalmology Society of India would like to do in the future. Any questions we will take up, any discussions we will take up now? Maybe some couple of minutes we can have some discussion. Good evening, Dr. Talwar. Good evening.
How are you?
Fine, sir. Fine.
I hear you talk about tele-ophthalmology and its use for screening. Hi, Ritesh.
Hi, Dr. Dinesh. How are you?
Ritesh is conducting the meeting today, so.
No, please. Really looking forward to this talk actually. Dr. Subudhi, how easy it has been for you to kind of training the paramedical staff to using these small handheld fundus cameras?
Yes. So, in this COVID period, this teleophthalmology, we have started teleophthalmology. So we have done virtual programs. There is a platform, ECHO platform. So both Joshi and ECO, we have joined together the last 6 months from July 2021 to December 2021. We got a series of virtual webinars where all our stalwarts like Natarajan, Dr. Kim, Dr. Rajiv, all have spoken to the at least more than 200 optometrists all over the country and abroad also. And shortly we are starting how to grade them, this diabetic retinopathy grading, image grading. Another 100 people are waiting for us to start the course. We will be starting shortly from the July 1st. So these are virtual mode, mostly.
Shivali, do we have any questions on the platforms?
Yes. Sir, any economical alternative to the handheld camera that you showed? Like, so what is the cost of that camera? How affordable is that to have THC in the center?
There are a lot of research is going on how to utilize your Android mobiles. A lot of devices come up and they're very, very economical. But whatever the device I've shown, the offline camera, it's approximately cost about 3 to 3.5 lakhs. It's not a very big deal. So if we can utilize these cameras, even in our ARC program recently, that 2 years back, we have utilized at least 6 cameras all over the country. So, but a lot of research is going on to utilize your Android camera with a small attachment. Even people have utilized this old IOLs to take the retina photographs. Even recently in a AIS conference, somebody presented in innovation, at least 4 lenses, 20D IOLs he taken. And he made a small camera-like thing and he has taken his Android mobile photographs. So a lot of things are coming up. Maybe within next few months or few years, we will be getting still economic models.
The other question related to the image capturing is, while doing the indirect ophthalmoscopy, is it possible with our phones to capture the image like what we are seeing on the 20D, like where to put the phone and how to capture the periphery if we want to?
Yes, but indirect ophthalmoscopy, of course, there should be a lot of attachment, camera attachments should be there to take the capture. But if you have a fundus cameras, nowadays this new fundus cameras have come where you can wide field cameras, so where you can take a photographs in the even extreme periphery of the retina, and 360-degree retina can be taken photographs. But indirect ophthalmoscopy, yes, it's you can visualize mostly.
I don't think it's relevant to this particular talk really. You see, the use of a smartphone for doing peripheral fundus photographs with the indirect. Yes, it has been done. It's done with a 20 diopter lens along with the camera. Images are okay. They are not bad. I don't know whether Ritesh has been doing them also. I think some of our people were trying them. Some of the. I'm sorry.
There's some voice from
Somebody is saying something.
No, there's a voice actually, some from background noise.
Background. So another question
but
is,
that has nothing to do, but that is not meant for screening diabetic retinopathy. The important thing is, okay, now actually what is more important for this group is what area needs to be screened when you want to screen for diabetic retinopathy. Maybe Dr. Subudhi, you could highlight that.
Yeah, majority of people in the urban areas, somewhere or other, they are screened. But the people living in the rural areas, they're never screened at all. They never screened. Of course, in the cities also, people come with the 5 years diabetic, but diabetic people, they have never screened in their life. But urban area, there are scope is there. But rural area, there's no scope, no hospitals. So that's why I'm insisting on that. If all the practitioners in the cities can find out sometime, at least once in a month, go to a rural place nearby, 30-40 kilometers nearby, and do some screening camps.
Yeah, see, the important thing is that screening for diabetic retinopathy is mainly for the posterior pole. Mainly the changes of diabetic retinopathy will occur in the posterior pole. So if you are able to get a fundus photograph of even a little beyond the arcade, you will be able to pick up patients who have significant diabetic retinopathy changes who require to be investigated further. So if you find a patient, whether using a smartphone device or even screening with an ophthalmoscope, I would even go to the extent of saying, if you don't want to spend 3 lakhs for a camera phone, even a direct ophthalmoscope is enough to figure out whether the patient has any evidence of diabetic retinopathy. And if there is any evidence of diabetic retinopathy, detailed evaluation can be done in a secondary care center, as was mentioned by Dr. Subudhi. So that is the important thing. It is not a difficult thing to screen for diabetic retinopathy. And of course, it is better to screen with a dilated fundus if you're doing with a direct ophthalmoscope, but with some of these smartphone cameras, non-mydriatic checkup is also possible. Another important thing to remember is the indirect ophthalmoscope is not a great idea for doing a screening retinopathy. It's not a very good tool. You could miss early diabetic retinopathy changes, but chances are you will not miss vision-threatening diabetic retinopathy. Ritesh, would you like to add something?
Yeah, I absolutely agree with you, Dr. Talwar. I know somehow the discussion was going more towards the camera, but herein it is important to get that man force to actually be able to screen diabetic retinopathy rather than focusing just on the camera. In India, instead of having a expensive equipments and treatments, it's more useful if we can train that much of manpower to use direct ophthalmoscope, basic cameras, pick up, refer, properly refer. That model of that pyramid where you have a stronger base and an apex center really works well for India.
Yeah, so if you feel that you have the technicians, you don't have the ophthalmologists, it's easier to train them with the smart cameras. Train them with the smart cameras. If you have a physician, the physicians should be trained to at least do basic diabetic retinopathy screening, so that they don't have to do any treatment. They just have to pick up, are there any changes? After all, what do you need to pick up? Are there any hemorrhages? Are there any microaneurysms? Are there any hard exudates? If any of these three things are there, send the patient to a higher center. Let them decide what is to be done after that.
Even the physicians also in their chamber, they can keep a direct ophthalmoscope.
Yes.
You look into the fundus. If you see a white dot or red dot, if white dot, red dot, they are suggestive of an exudate or a hemorrhage. So first refer the patient to the nearest ophthalmologist. They should do that, but they're not doing it.
Yeah.
Many endocrinologists I'm seeing, they're the roaring practitioners of our country. They do practice in cities, but they never refer the patient to the ophthalmologist, fearing that either they lose the patient or the patient will not come back, or the ophthalmologist will keep the patient with him. So these are the, most of the times we fear whether we may lose the patient by referring to somebody else.
That's right. All big diabetic sir, if they start having one proper mode of screening at their center, that's the primary level screening that one needs in India.
In tele-ophthalmology, what they're planning now, a lot of school dropouts and college dropouts. In particular, they are in the rural areas. You select them, give a nominal fee, train them physically, how to handle the cameras, give a camera and ask them to capture the images. And if this camera has got AI incorporated, but it becomes easier for us to grade the images, and where you can detect whether the patient is, the image is referable or non-referable. The case is referable, non-referable. Then if it is referable, then you can send to the secondary care center. Even the government has also come up for laser. They have the free treatment for the lasers. Even some hospitals, the intraocular injections are also available free in the government hospitals.
There's a question over here that screening in rural and semi-urban areas is to be carried out by vision care providers.
Yes, sir.
So will that be, how would you make that an effective approach? Because will that be effective to do the screening? How will they do the screening?
They can go to the door to door. Okay, they have the camera.
Okay.
They select the patient. Okay, so if the patient doesn't have a cataract or something opacity in the media, if they can capture the image easily. And once they capture the image, this captured image can be transferred electronically to the nearby center, or the camera itself can be brought to the center for again the image analysis. So this can be possible.
Okay, so actually these smart cameras actually have a net connection. So if this, and I think the city, the country is now getting connected to the net in a very large way. So
Yes.
there are very, very small pockets left where they don't have net connectivity. So these images can be transferred to bigger centers where they can analyze the images, and those patients who need to be further investigated can be investigated. So it's a good idea if it works out. It's a good use of technology. And as we said before, I mean, in areas where there are people coming for a checkup, they should all be checked up for retinopathy. That mass movement needs to be carried out too.
Dr. Talwar, also I feel in this area, the AI is really working and improving pretty fast. I have tested a couple of AI models for diabetic retinopathy along with different cameras, and they are really now improving. And wherein you have a fear that people may not, or you don't have trained people there, now these small cameras with AI enabled will give you a report saying refer or not refer. We just want that much. That is the basic minimum you want. Refer or not refer. And once you get a refer on it, you immediately have a tie-up with the next level center and you move the patient there. So that is the aim with which a lot of this community programs with AI are working.
Yeah,
so lot of innovations also coming up with the cameras. Hundreds of cameras now available in the market to take the photograph of retina.
Yeah, so that answers both the questions about door-to-door reaching out to people. That is being planned out. This is being done, I think, at a state level, if I'm not mistaken, isn't it? like you were talking about the Odisha model. So it's basically a state level. The healthcare programs are generally carried out at a state level, and then so that there are differences in their planning. I don't think there's a central level program. Is there a central level program also which is going on?
At present, no. At present, no. But actually, it's coming universal eye care. Universal eye care is by a central government program, and probably it is not yet into the force. That's it. In Odisha, we have this Sunetra program. We have started 2 years back, and our aim is to this whatever I told the model. So we will post ophthalmic assistants or optometrists for every 50,000 population, and they can just somehow some sort of they can do the screening and in the rural areas. That is the plan.
Okay. Are there any more questions, Shefali?
Yes, sir. So one question is regarding the collaboration with the endocrinologist, because they say that not many, in fact, very few endocrinologists advise their patients to go for the eye screening. So how do you overcome that challenge? Like, how do you collaborate with them or increase awareness in that society, that community, to refer the patients to ophthalmologists?
Yeah,
yes.
Dr.
Yeah, Dr. Talwar, yes, please.
Yeah, so actually, I think that is where we need to develop CME programs which are multi disciplinary. What happens is the physicians have their own conferences, the endocrinologists have their own conferences, and the ophthalmologists have their own conferences, and never the twain shall meet. So what we need is that we should be part of their conferences, and they should be part of our conferences, which is something which we see more often now. I mean, I remember the Delhi Retina Forum did 1 or 2 such programs where they called people from nephrology and endocrinology and cardiology to participate in our program on diabetes. So which is the kind of programs we need on a regular basis, where this information gets, it percolates to down the line to others also. In fact, I've been part of last 2 years, I've been a part of many such programs where you have the physicians and the ophthalmologists and the cardiologists, the endocrinologists, together with general physicians. And one realizes that there is actually a lot of curiosity about the effect on the eye of diabetes. So this is there is an unmet need. We need to fulfill that. And I suppose it would need to be the organizations which are here, the AIOS, the Daily Ophthalmological Society, along with the physician organizations. They need to get together and have programs which involve them all, which involve us all. So and of course, at a personal level, whatever we can spread, we should spread that information.
It's something like what the National ROP Society, Dr. Subhadra Jalali and everybody did with ROP, where they made sure that ROP came as a part of pediatric textbook, because they were also struggling with that screening. It's now become a part of one of those checklists which every pediatrician has to mandatorily go through if he's getting screened. So similarly, either the AIOS Diabetic Retinopathy Task Force can somehow get this into the medicine curriculum at that level itself. That is where it should eventually be aimed at.
We also insist to the endocrinologists, when they treat the diabetes patient, they should have a checklist. Whether the patient had undergone any time eye checkup, they should put a tick mark. If it's not done, ask them to, they will say that go to the eye doctor, check the eye and come back. I will see the patient. This sort of should be necessary.
Actually, it should be both ways. When we see a diabetic, we should tell them to go to their endocrinologist and get their blood sugar checked also.
We do, definitely we do. Because when we do a cataract surgery or
glaucoma surgery, if it is both ways, it will catch up.
Yes. Right.
Dr. Subudhi sir, so you were mentioning about a portal which is available for our optometrists to get the training, the basic training. So could you just mention about the channel or the website where they can actually avail those webinars?
Yeah. But shortly we are coming up with this TOSI Eco webinar, and I will be shortly, putting that, because we are planning on that, working on that model. There were the 4 sessions. we will invite some experts from different parts of the country, those who have got a teleophthalm set up in their institutes like LB Prasad, Sankanetrale, Arvind. They are the experts for this. And we'll have a series of meetings. And shortly we are coming at this. It's not not to the web, it will be webinars. 4 webinars every fortnight, one each from July, mid-July onwards.
There's a question here on diabetic retinopathy screening in HbA1c. HbA1c is not a reliable marker of the stage of diabetic retinopathy. There are patients who may have a high HbA1c and no diabetic retinopathy, and vice versa. Yes. So therefore, you cannot substitute HbA1c levels for screening for diabetic retinopathy. It has to be done. The basic patient who needs to be screened. I think it's important to mention that any diabetic who has NIDDM needs his first screening at the time of diagnosis. This is very important. On the other hand, if there are IDDM patients, actually within first 5 years, they don't need that much of screening. So you could delay screening for up to 3 to 5 years in IDDM patients. There are also patients who get IDDM before puberty must have their first screening at puberty itself. There are children who have IDDM before puberty. They develop IDDM before puberty. They must be screened at puberty. After the first checkup, the subsequent screening or subsequent follow-ups are then done as per the first screening results. If there is no diabetic retinopathy, the patient may be followed up on a once-a-year basis. If there is some degree of retinopathy, depending on the severity, follow-up may be anything between 3 to 6 months. But the first screening of a diabetic retinopathy patients in NIDDM, it must be done at the time of diagnosis, because up to 20 to 25% of patients with NIDDM could have diabetic retinopathy at the time of diagnosis. So this is very important.
And one more thing, that the regional variation. If you see the southern population, particularly Kerala, Tamil Nadu, they got a more incidence of diabetic retinopathy. When Punjab also, they got a high incidence of diabetic retinopathy. With other states like our eastern states, many of the eastern, they don't have much amount of. So we should have an aggressive screening program, but those states where they got a high prevalence of diabetic retinopathy.
Okay, another question has come about diabetic retinopathy severity. No, diabetic retinopathy severity is not more in NIDDM. We talked about the incidence, the development of diabetic retinopathy coming. The reason why in NIDDM you can have diabetic retinopathy at diagnosis is because NIDDM itself is missed for many years. Very often NIDDM is missed because the patient doesn't have severe. By definition, IDDM cannot be missed. It's an insulin-dependent diabetes mellitus. Within 4 to 6 weeks of the disease symptoms coming, the patient has to be set on insulin, otherwise he would die. So the diagnosis can never be missed. You know the exact point of onset of IDDM. NIDDM, on the other hand, is not that severe a disease process. Therefore, many years may pass before the disease may be caught. And that is why at diagnosis itself, patients may end up having some degree of diabetic retinopathy. Now, severity of diabetic retinopathy now is at 2 levels. One is severity from non-proliferative to proliferative changes. So that is a time-bound thing. It's not going to happen because it's been there for 3 years or so. So it's not that that PDR is more in NIDDM, not true. Diabetic maculopathy, you will find more often in NIDDM than you will find in IDDM patients, because that happens earlier in them. So this is true that moderate vision loss because of diabetic macular edema is more common in NIDDM. So this is that is true. I wanted to ask you, Dr. Subudhi, one question. These artificial intelligence machines, which Sundar Pichai was talking about, are they able to pick out that this patient whose fundus I have seen actually has proliferative diabetic retinopathy? whereas actually there may not be NVD there.
Yes.
That's what what I mean is, like, sometimes, like, we've heard that it can pick up cases of which are likely to go into myocardial infarction. So does it pick up that this patient is PDR or likely to go to PDR in 1 year?
I don't yet present till date. I don't think there is, but the research may come soon. Innovations are going up, and research nowadays we get better. So probably in a couple of years we may be getting that.
Okay.
So they are able to pick up PDR, but likelihood to PDR is still
The conversion from
yes. You see, if they can pick up, this guy is going to get an MI. I mean, that is way beyond. No, that is something else altogether. Then why not pick up that? It should be able to pick up that. Look, this guy's got the kind of changes which will go into severe PDR.
The problem there is, as ophthalmologists, we have to train the AI. Can we look at the fundus and tell that this is the change which is likely to
but
take?
Ritesh, that's not true. We haven't trained the AI to pick up which patient will get an MI.
No. MI, based on MI yes or MI no, they are calibrating the vascular caliber with it.
Yeah.
But an ophthalmologist has to tell this NPDR finding will lead to PDR. If we start pointing those more often to AI will pick up. AI will
but actually, they are supposed to have their machine learning algorithms actually help them to pick this up on their own over time. That's what I wanted to ask him. That are the machine learning? Yes, that are the machine learning algorithms capable of now reaching that stage or not?
Till date, there are only few images are fed to the AI. I think we need more images to be fed into the AI to, analyze these things.
So for those who are listening, see that there is potential, but remember, quality of image is a major deterrent to further development. So you have to have very good quality cameras. You have to have wider field cameras to be able to pick more and more. So as the technology develops, probably the ability to do the screening will also improve.
Right.
So Shefali, do we have any more questions, or are we?
We have covered all the questions on the portals across all portals.
Before you close and vote of thanks, I request all of you to become a member of Tele-ophthalmology Society of India. So I request all the viewers also, let us become to see the future. Tele-ophthalmology Society is the future of our country, particularly ophthalmology. So be a member and enrich our knowledge and enrich our power, so that at least we can achieve our success. Thank you.
Thank you. Thanks a lot, Dr. Subudhi.
Ritesh to please conclude the session.
Thanks a lot, Dr. Subudhi, for such an enlightening session, such an entertaining and interesting session. It was indeed a pleasure to be there in this meeting. Thank you, Dr. Talwar, for taking out time for this interesting discussion. Thanks, Shefali, for moderating it so well. Thanks a lot. And Shefali?
Next lecture, next on June 22nd, we are concluding our Retina series with an exciting Retina quiz. So I invite all of you to come test your knowledge post these lectures with our UC team. So see you all there on June 22nd.
Thank you. Bye-bye.
Thank you, sir. Thank you. Thank you, Ritesh and Shefali. Thank you. So nice. We learned a lot.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Bye. Bye. Good night.